Let you.
So let me know after 10 seconds, I will start.
Okay, sir. Okay.
So let me
Yes,
know
sir,
after 10 seconds, I will start.
Live. Okay, sir. We can start.
Yeah, good morning, everyone. First of all, thank you for investing your time on this Sunday morning. I am Jitender, and I am from Pfizer INI RDT. So today we have an amazing panel on growth update, where we will be talking about the need to establish the role of growth hormone deficiency and overview of slow teacher. So first of all, I will introduce our eminent moderator to you. We have Dr. Aniket Khamboskar. Dr. Aniket has done MBBS and MD Pediatrics, PDCC, Pediatric Endocrinology, and European Society of Pediatric Endocrinology Fellow from UK. Dr. Aniket is an Associate Professor in Pediatric Endocrinology at Department of Pediatric Bhartik Hospital, Sangli. He is working as a consultant pediatric and adolescent endocrinologist at Grow Kids Endocrine Clinic, Kolhapur and Sangli. He is an active member of Growth Hormone Research Society of India and involved in various activities in this society. In addition, he is a member of Indian Society of Pediatric Endocrinology, Asia Pacific Pediatric Endocrine Society, and International Society of Pediatric and Adolescent Diabetes. So with this, now I am handing over the dais to Dr. Aniket Khamboskar for further proceedings. Thank you all.
Good morning, everyone. So today we are here with the exciting discussion on very important topic, which is common problem in day-to-day OPD. And the main discussion will be done by Dr. Chirantap and Dr. Nikhil. And I would just like to introduce the topic and then we will go further. So may I share my screen?
Yes, sir.
Is it visible?
It's visible, sir.
Okay. So we will just first understand the burden of this problem globally and then national level. So short stature is defined as height that is 2 or more standard deviation below mean for age and gender within a population that is below third percentile. About 2% of all children or more than 1 million children in US present with short stature. And boys come to medical attention because of short stature more frequently than girls, even in developed countries. In developing countries, short stature is often a consequence of malnutrition, and the prevalence rates for stunting in adolescent and children range from 9% to 11% in South America and are as high as 30% in certain parts of Africa. Now, a study conducted by Al Muzan in Saudi Arabia reported that the prevalence of moderate short stature was 11.3% in boys and 10.5% in girls, while the prevalence of severe short stature was 1.8% in boys and 1.2% in girls. By using the 1978 World Health Organization and the 2000 CDC and 2007 WHO growth reference, the prevalence of moderate short stature was 12.1%, 11%, and 11.3% in boys, and 10%, 10.9, 11.3, and 10.5% in girls. So ranging from almost 9 to 12%. The prevalence of stunting in rural region in South Africa was 5 to 7% in children and adolescents between 5 to 20 years. A Pakistani study stated the prevalence of short stature was 16.5%, which is highest among the 6 to 12 years. So in UK, out of 5,000 infants born in 1960, 111, that is 4.5%, who were measured at 10 years were below third percentile, and 16 had unsuspected cause of short stature. In US, among 555 of 79,495 children who were short. Familial short stature and CDGP accounted for 75% cases, and 40% had underlying organic disease. Only 5% has endocrine cause. Shiva et al. Reported familial short stature in 33.6%, and constitutional growth delay 19.7%, idiopathic in 11%, and IUGR among almost 10%, and hypothyroidism in 2.5% cases of short stature from Iran. The prevalence of short stature in India, although is comparison between South India with the same ethnic background in living in Dubai is showing that the prevalence of short stature which are living in India was 38.8% and 36.9% in boys and girls, compared to 9 to 11% who are in UAE. A study by Firke et al. On 49 children with 73.4% pathological type revealed that 77% were proportionate, and chronic systemic disorder were detected almost in 25%. So, I mean, just to understand this is, since height is a dynamic process, some of the children which are totally normal may fall below third percentile, and they may spontaneously show catch-up on follow-up. So rather than just studying the prevalence or one point of view reading, it is more important to do a serial growth monitoring in children. And those who are persistently falling below third percentile, or in which the documentation of growth velocity is persistently subnormal, those group of patients should only be investigated thoroughly. Other than that, other patients can be monitored clinically if there are no organic disorders on detailed clinical examination. So, what is I think the other speakers will focus and discuss about these different types, like FS, what is familial short stature, what is idiopathic short stature, and actually these are the terms which are used when we these are the terms which are labeled only when you do exclude other causes. So FSS and ISS are diagnosis of exclusion rather than a specific diagnosis per se. And when you exclude all other possible causes and you don't find any cause, then only you have to label the patient as FSS or ISS. And again, these are heterogeneous group of patients, and they may respond very differently to your growth augmentation therapy. So just to highlight the common causes which can lead to short stature are gastrointestinal, like celiac disease, Crohn's disease, cystic fibrosis, hepatic, chronic hepatitis, renal problems, glomerular, like nephrotic syndrome who was on steroids, or some interstitial nephritis, or tubular dysfunction, simple disorders which can lead to short stature without obvious clinical clues. We should think of tubular disorders because they may not always present with you with acidotic breathing and florid signs. So renal tubular acidosis is one such disorder which can present only as short stature with some signs of rickets, and you have to have thorough clinical acumen to suspect these causes and identify in time so that you can treat properly. Then cardiac causes are generally obvious. They will present with cardiac symptoms and they will have recurrent respiratory tract infections. And we know that it is obviously these cardiac lesions which are causing failure to thrive and short stature. Pulmonary disorders like chronic asthma in preterm babies who are subjected to ventilation, BPD, obstructive apnea, pulmonary sequestrations, and other pulmonary disorders can also present because of chronic hypoxia. Metabolic. So the most common metabolic cause which we see in our OPD is diabetes, which if it is poorly controlled will significantly lead to both underweight and short stature. typical, Mouriac syndrome type picture. Then chronic severe anemia can also present with severe short stature if it is not identified in time. Some of the hemoglobinopathies like beta thalassemia intermedia can go unrecognized for many years and can just present with short stature. Then obviously oncological causes will have some obvious clues, and CNS and rheumatological disorders will present with their set of symptomatology. Now, we will just discuss about common endocrine causes like growth hormone, hypothyroidism, precocious puberty, inherited rickets, and DI without treatment. Now, this is just a guideline how we should measure the growth. So infantometer should be used in less than 2 years with with 2 persons, and we should measure the length twice and take an average of that. And stadiometer should be used for older boys and girls, and accuracy should be to at least 2 to 4 m. And then if we are in doubt, we should take 3 measurements and take a average of that. And mid-parental height, all of you know that it is average plus 6.5 centimeters for boys and minus 6.5 for girls. And it is very essential for every patient to compare the height with respect to mid-parental height, because sometimes even if height is in normal centile, patient may have organic disorder if they are way below the mid-parental height. Growth velocity, again, as I discussed, rather than one measurement, serial measurements and calculating growth velocity is more important for identification of growth disorders. So accurate height measurement, accurate body proportion assessment, and height velocity assessment with comparison to standard. So less than 5 years, we will compare with WHO charts, and more than 5 years with the IAP charts. So this is a IAP chart, and there are n number of clues which are there, which we should not miss when we examine the patient. So like in achondroplasia, we can get a disproportionate and short stature with large skull and typical dysmorphic features. MPS will have coarse faces, hepatosplenomegaly. GHD patients will have typical GHD faces with mid-facial hyperplasia. Then hypothyroidism, if it is long standing, will present with all signs and symptoms. Turner syndrome can present just as short stature, but if it is associated with stigmata, then you will obviously not miss it. And certain syndromes should be taken care of, like Russell-Silver syndrome and Down syndrome and Noonan syndrome, which are actually common but missed many times in a OPD basis. So always see for these clues on examination, and obviously the puberty assessment is a very essential part of your examination, and it will definitely help you in coming to diagnosis of either CDGP or hypogonadism or as a cause of growth disorders. So I think rather than discussing further, I will end my slides here, and I would go for the introduction of next speaker. So we have Dr. Chirantap Oza. He's a young dynamic pediatric endocrinologist who is hailing from Ahmedabad, and he is visiting consultant at Narendra Modi Medical College and Gujarat Cancer Society Medical College. And he has around 30 indexed publications in national and international journals. So we are very eager to hear from you, Chirantap.
Thank you so much, Aniket sir, for the kind introduction. If I could just share my screen. Correct. I hope my screen is visible. So, good morning, everyone. And today I would be discussing a case-based approach to short stature. And I'm working as a consultant pediatric endocrinologist in Ahmedabad, Gujarat. So, without wasting any further time, I'll go ahead with the discussion. So, disclaimer that the content in this presentation is only intended for healthcare professionals in India, and the company does not endorse any views that are mentioned in here. So the first case, we have a 13-year, 6-month-old boy who presented with complaint of short stature as compared to his peers. On detailed history, the mother mentioned that the child has always been short since birth, and there is family history of short stature in both the parents. He was a full-term vaginally vertex delivered boy with weight of 3 kg at birth without any significant perinatal history. There is no history of any chronic systemic illness that required long-term medical therapy. On general and systemic examination, no significant positive finding was noted. The SMR, the sexual maturity rating of the child was A2, P3, G3, T15, T15 that came down to Tanner stage 3 for boys. So now plotting the child on the growth chart, his height was 140 centimeters and his weight was 30 kgs. Now we had luckily some few past records on height on this child. So at 1.5 years age, his height was 75 centimeters. At 4 years, it was 90 centimeters. And at 9 years, it was 115 centimeters. So as we can see, the height has remained on the same trajectory since the age of 1.5 years. Now, as both the parents were present with the child, we plotted the height of parents on the mid-parental height percentile calculator tool, which is present in the pediatrician-friendly growth charts. So the father was 151 centimeter and mother was 145 centimeter. Now connecting both the lines where they cross the MPH centile, showing it on the father's side, we get a mid-parental height of 154.5 centimeter for a boy. So now with this details, what could be the probable diagnosis in the child? So as we can see that the height is small since birth and it is falling in the mid-parental height range. This is most likely familial short stature. So the questions to be answered are, is the child really short? So short stature is defined as height less than -2 standard deviation below the mean height for their gender and chronological age in a given population. So yes, our child in the case is actually short because for Indian boys, his height is less than the 3rd centile. But is it pathological or physiological short stature? So severe short stature is defined as height less than -3 standard deviation. And when it is severe short stature, it is more likely to be pathological. And between -2 to -3, of course, with exceptions, but it is usually physiological short stature. So what is the significance of birth history in these cases? So a small for gestational age child may fail to catch up. That would be discussed in detail in the next session by Dr. Nikhil Shah. And also that breech delivery is associated with growth hormone deficiency or multiple pituitary hormone deficiency. So that is the significance of birth history in these cases. So now going to the approach step by step, if the height of the child is less than -2 standard deviation and the child follows his or her own growth curve, and there is any history, family history of short stature or pubertal delay, if the answer to all these questions is yes, then it is more likely to be a physiological short stature and one must do bone age assessment and take mid-parental height. If bone age and chronological age are same and the height is in the mid-parental height range, then the cause is familial short stature. But if bone age is less than chronological age and bone age is equal to the height age of the child, it is more likely to be constitutional short stature. If the height is less than -3 standard deviation, as mentioned earlier, it could be pathological cause of short stature. So how can we differentiate between the two physiologic forms of short stature, that is familial and constitutional delay in growth and puberty? So familial short stature is short since birth. There is family history of short stature in parents or grandparents. The pubertal development is normal for the age, and the final height is short but within the mid-parental height range. Whereas for constitutional delay, the growth retardation begins by the age of 2 to 3 years. There is family history of delayed puberty rather than short stature. The pubertal timing is delayed in these children, and the final adult height is normal. That is, the final adult height, the child is not short for the given population and mid-parental height. So in the history, we had mentioned that there is no history of any chronic illness that required long-term therapy. So which chronic diseases are associated with short stature? So it includes malnutrition, chronic kidney disease, congenital heart disease, asthma, cystic fibrosis, celiac disease, sickle cell anemia, thalassemia, and diabetes mellitus. Now, what is the importance of plotting weight in cases of short stature? So if the weight is affected more than height, then it hints towards malnutrition, chronic disease, renal disease, or psychosocial neglect as etiology of short stature. And if at all, what should be worried for in this case? So exclusion of familial causes of growth retardation, such as GN gene mutation, PROP1, PIT1 mutation, or skeletal dysplasia that run in the family may be the cause of short stature. So that is one thing that we should be looking out for and rule out before labeling as familial short stature. So like discussed earlier, what is importance of weight in these cases? So first of all, here, what we need to do is plot the height age and the weight age of the child. So considering the weight of the child, we should draw a line which is parallel to the x-axis in such a way that it intersects the 50th percentile line on the growth chart, and then draw it, extend it vertically parallel to the y-axis in such a way that it intersects the x-axis. The point at which it intersects the x-axis becomes the weight age of the child. Similarly, for height, extend the line horizontally up to the 50th centile and then draw it vertically such that it intersects the x-axis, and that gives us the weight age of the child. So if weight age is less than height age, as in this case, where the weight age is close to 6.2 years and the height age is around 9.5 years, malnutrition, chronic disease, renal disease, and psychosocial forms of short stature must be considered as etiology. So the points to remember from the first case are: plotting height and weight is equally important to maintain growth record. One must use population-specific growth charts, that is WHO 2006 for under 5 and IAP 2015 for 5 to 18-year-old children. One must always interpret height in relation to the mid-parental height to avoid unnecessary burden of investigations. And assessment of pubertal status is helpful in differentiating familial cases of short stature from CDGP without doing any investigation. But if we have to do an investigation, bone age might be useful in guiding us for the diagnosis. Now, moving on to the next case, we have a 13-year, 6-month-old girl who presented to us with complaint of short stature. She was born full term with a birth weight of 2.2 kg by cesarean section. On asking positively, the mother confirmed that the child had history of lymphedema of hands and feet at the time of birth. On examination, she had short webbed neck, low posterior hairline, and multiple nevi on back. There was no history of any renal or cardiac disease. On examination, she had a firm bossylated goiter in the neck, and her SMR staging was A1, P1, B1, B1, which is Tanner stage 1, that is prepubertal. Now, these are the images of the child. So as we can see that for a 13-year-old, the girl is really short. The low posterior hairline can be seen. This is increased carrying angle, that is cubitus valgus is present. As we can see in this image, there is dimpling on the on the fourth knuckle. And this is the bone age X-ray of the child, where we can see that the fourth metacarpal is really short. So the differentials for short fourth metacarpal include Turner syndrome, Shock's gene mutation, and pseudo hypoparathyroidism. So then plotting the girl on the growth chart, we can see that for 13.5 years, her height is 115 centimeter and weight of 33.7 kg. The mid-parental height was coming down to 150 centimeter. So the child is really short, whereas weight is not that affected. So this is pathological severe short stature. So there might be some pathological cause. First line investigations were done, wherein hemoglobin was 12.5%. Creatinine was 0.8 milligram per deciliter, which is normal. The TSH was 195 micro international unit per ml. Free T4 was not detectable. FSH was 169.8 milli international unit per ml, and LH was 23.3 milli international unit per ml, while estradiol was undetectable. So in view of elevated TSH and undetected free T4 with presence of goiter, so biochemical picture of hypothyroidism, thyroxine was started in this girl, and a karyotype was sent for premature ovarian failure considering hypergonadotropic hypogonadism, because the gonadotropins, that is FSH and LH, are very elevated, but estradiol is undetectable, and after crossing 13 years, still the child is prepubertal. So this is the karyotype image of the patient, and as we can see in the bottommost row, there is only presence of single X chromosome. So this is 45XO, which is Turner syndrome. So now on plotting the girl on Turner syndrome specific Indian charts, here we can see that at 13.5 at 115 centimeter, she's even short for the Turner growth charts. So that might be suggestive of some coexisting comorbidity like hypothyroidism or celiac disease. Now she was started on thyroxine, and besides that, recombinant human growth hormone was started at a dose of 50 microgram per kg per day, and oral estrogen was also started to induce the pubertal changes in her, and the response is as shown in the figure. So at 14.5 years, she was 125 centimeter, and at 15.5 years age, her height was 133 centimeter. So she reached the median height for the Indian Turner girls, but as compared to normal, otherwise healthy Indian girls, her height still remained below the third centile, but the catch-up that we can see here is spectacular. So growth hormone, induction of puberty, and correction of hypothyroidism helped in increasing the height of this child. So now some rapid fire spotters. So as we can see in this image, it's a 3-year-old male child who was brought with complaint of short stature, disproportionate short stature, frontal bossing, depressed nasal bridge, trident-like hand, and lordosis. So for disproportionate short stature, wherein there is short limb short stature, one must think of skeletal dysplasias and mucopolysaccharidosis, presence of frontal bossing, depressed nasal bridge, trident-like hand, and the shortening of the arm and leg of the child, that is humerus and the femur portion of the child. This is rhizomelic shortening, so a cause of disproportionate short stature. So this is more likely to be achondroplasia. Now this is a second child who is a 4-year-old male who was born small for gestational age, had triangular faces, asymmetry, and as shown in the smaller image, clinodactyly. So this is more likely to be Silver Russell syndrome. Now, this was a 7-year-old male child who was brought to us with complaint of growth concern, ptosis, cryptorchidism, learning difficulties, and history of heart defects. So this could be probably Noonan syndrome. Whereas this is an 8-year-old obese boy with delayed milestone, difficulty in feeding in the newborn and infant period, failure to thrive initially, followed by obesity, subnormal intelligence, habit of constant skin picking, and hypogonadism. So this could be a Prader-Willi syndrome. So moving ahead in the approach, if height is less than -3 standard deviation, one must look for pathological causes of short stature. If weight age is less than height age, it could be malnutrition, chronic disease, or psychosocial short stature. But if height is more affected than weight, then one must look for dysmorphism and disproportionate limb shortening. If there is any dysmorphism, then it might be suggestive of syndromic form of short stature. And if there is any disproportionate limb shortening, one must look for skeletal dysplasia or mucopolysaccharidosis. If there is no dysmorphism or disproportionate limb shortening, endocrine cause of short stature must be evaluated for. So the points to remember from this case are: detailed history and examination are very critical for identification of etiology of short stature, particularly the syndromic form. Dysmorphism must not be taken lightly in case of short stature. One must plot the patient on disease-specific growth chart to identify coexisting comorbidity, like hypothyroid in our case of Turner syndrome. And X-ray is useful besides bone age assessment to identify short fourth metacarpal, skeletal dysplasia, and McCune-Albright syndrome, which is a cause of precocious puberty. Moving on to the next case, we have a 7-year-old boy who presented to us with no gain in height and excessive weight gain since last 2 years. He was a full-term vaginally delivered 2.8 kg appropriate for gestational age boy with no significant perinatal history. The mother complains of excessive sleep. We can see dry skin, lethargy, and constipation. On examination, proximal myopathy in lower limb was noted with small goiter in the neck. There is no purple stria, acne, or hypertension when the child was examined. And the SMR stage of the child was A1, P1, G1, T2, T2, which is Tanner stage 1, prepubertal. So plotting the child on growth chart, the height of the child was 100 centimeter, weight was 30 kg, mid-parental height was 167 centimeter. So as discussed earlier, on extending the line to the 50th centile on the height standard and then pulling it down vertically, when it intersects the x-axis, it gives us the height age of 3.6 years. The weight age similarly was obtained of 9.6 years, and an X-ray of bone age was done that gave us bone age of 3 years. So weight age is more than chronological age, which is more than height age, and a delay in bone age of more than 2 years. This is more likely to be an endocrine cause of short stature. So endocrine short stature is classically seen as a short and fat child with delay in bone age of more than 2 years. On performing the first line investigations in this child, hemoglobin was 13.5%, creatinine of 0.6, TSH was more than 100 micro international unit per ml, free T4 was less than 0.4 nanogram per DL, and free T3 was 0.3 picogram per ml. To confirm the etiological cause of short stature, anti-TPO and anti-TG antibodies were performed, both of which came to be positive. So the diagnosis of acquired autoimmune thyroiditis was made for this child and was started on levothyroxine. The patient is yet to follow up. So the response to treatment, I'm not able to show right now. Moving on to the next case, we have a 5.5-year-old girl who presented to us with complaint of failure to thrive. She was born by breech presentation to third-degree consanguineous parents with birth weight of 2.9 kg and birth length of 49 centimeters. She had history of NICU admission for neonatal hypoglycemia. There was no history of neonatal jaundice in the child. On examination, she had frontal bossing, mid-facial hypoplasia, immature doll-like faces, delayed dentition, depressed nasal bridge, central fat deposition, high-pitched voice, small hands and feet, and hypoplastic labia. On plotting her anthropometry, her height was 91.1 centimeter, which is a Z-score of -3.8. Her weight was 12 kg, giving us a BMI of 14.4 kg per meter square. The mother's height was 149 centimeter and father's height was 171 centimeter, giving us a mid-parental height of 153.5 centimeter. So as we can see that the child is short below the third centile, we can say that yes, it is severe short stature because Z-score of less than -3 is present. Weight is also affected, but height is affected more than weight. So this is more likely an endocrine cause of short stature. So the investigations that were performed revealed hemogram, blood glucose, renal function, liver function tests to be normal. The thyroid function test and cortisol was also normal. This is the X-ray bone age image of the child, and a bone age of 2.7 years was calculated using the Tanner-Whitehouse method. Serum IGF-1, which is insulin-like growth factor 1 value, was sent, and the investigation showed low serum IGF-1, which was 33 nanogram per ml. Normal range for a 2 to 6-year-old child is 51 to 303. A growth hormone stimulation test was performed with clonidine, and at baseline, the growth hormone level was 1.09 nanogram per ml. At end of 1 hour post-stimulation, it was 2.99 nanogram per ml. And at 2 hours, it was 1.86 nanogram per ml. So the child failed the growth hormone stimulation test, and thus an MRI of brain was performed. And as you can see by the two arrows, the first arrow is pointing at the hypoplastic anterior pituitary, and the second arrow is pointing at ectopic posterior pituitary. So MRI was small for age pituitary gland size, which was 4.5 by 7 by 2.5 mm, and pituitary stalk interruption syndrome, wherein interrupted or thin pituitary stalk was seen with anterior pituitary hypoplasia and ectopic posterior pituitary. So the diagnosis of isolated growth hormone deficiency was made. She was started on 20 microgram per kg per day of recombinant human growth hormone, and the dose was slowly increased to 30 microgram per kg per day. And the response that we could see is as shown in this growth chart. So we started the growth hormone at age of 5.5 years with height of 91 centimeter. So at 6 years, 3 months, her height was 97.2, which is a Z-score of -3.2, an improvement of 0.6. Then at 7 years, 7 months, her height was 107.3 centimeters, which is a Z-score of -2.6. At 8 years, 10 months, her height was 116.8 centimeter, which is a Z-score of -2.1. And at 9 years, 9 months, her height was 122.5 centimeter, which is a Z-score of -1.9. So from being a severe pathological short stature, the response to growth hormone, she's now just about on the third centile, which is Z-score of -1.9. So this is how amazing response of growth hormone can be seen in children with growth hormone deficiency. So the points to remember from this case are: endocrine short stature is characterized by a short and fat child. However, in Indian scenario, it is not always true, and growth hormone deficiency may have retarded weight along with retarded height. Growth hormone stimulation test and MRI are both useful in identifying growth hormone deficiency. Response to recombinant human growth hormone therapy is spectacular in cases of growth hormone deficiency. Etiological diagnosis is must for treatment of short stature, as growth hormone is indicated in growth hormone deficiency and in various other indications as well. Now, a child with similar history as in the previous case presented to us. This is how the child looks like. She's a girl and they presented to us at age of 1.6 years with history of failure to thrive. At 1.6 years, her length was 55 centimeters and weight of 4.5 kg. Investigations were sent and it showed normal hemogram, creatinine, thyroid function test, cortisol level, but growth hormone stimulation test was performed and the levels were less than 0.05 nanogram per ml at baseline 1 hour and 2 hour. IGF-1 level were also very low, 1.1 nanogram per ml, and IGF-1 binding protein 3 were undetectable. MRI was suggestive of small pituitary size for age with no other abnormality noted. So considering a diagnosis of growth hormone deficiency, she was started on growth hormone therapy, and at age of 2.6 years, she was 68 centimeters. At age of 3.6 years, she was 74 centimeters. But by the age of 5.5 years, she was only 79 centimeters. And at 6.6 years, her height was 83 centimeters only. So after a good initial response to growth hormone therapy, the response flattened and a height gain of only 5 centimeters was noted in 2 years. So genetic evaluation was performed and it showed that there is a mutation of GH1 gene, which is homozygous autosomal recessive inheritance, which is likely pathogenic. So growth hormone was not produced in the fetal life in this child, and these patients may be immunologically intolerant to growth hormone, and treatment with growth hormone leads to development of anti-growth hormone antibodies over time, and the treatment with growth hormone becomes ineffective. So in summary, if there is any child with short stature, one must exclude small for gestational age, psychosocial neglect, and systemic illnesses. If there is any dysmorphism, then one must look for syndrome-specific signs of short stature. If there is disproportionate short stature, one must evaluate for skeletal dysplasia. If there is no dysmorphism and height is between -2 to -3 standard deviation and bone age is within 2 years of chronological age, it could be familial or constitutional delay. If weight is affected more than height, it would be malnutrition or chronic disease. And if height Z-score is less than -3, bone age delay is more than 2 years, then one must look for endocrine causes of short stature. The take-home messages from this session are: plot every child accurately on growth chart along with using mid-parental height and weight for height tool. Detailed history and examination hint towards an etiological diagnosis, which should be further confirmed with investigations. Genetics and other second-line investigations like growth hormone stimulation test and MRI are helpful, but must be used judiciously. And growth hormone may be used for license indications to improve the stature of child. This is a small detail about the recombinant human growth hormone, which is recombinant somatropin. So as mentioned, the indications of giving growth hormone includes growth hormone deficiency or multiple pituitary hormone deficiency, Turner syndrome, Noonan syndrome, Prader-Willi syndrome, Shock's gene mutation, chronic kidney disease, idiopathic short stature, and small for gestational age that would be discussed in the next session. The contraindications of giving growth hormone therapy include evidence of neoplastic activity, anti-tumor therapy, acute critical illness due to complications following open heart or abdominal surgery, multiple accidental trauma or acute respiratory failure, and hypersensitivity to any of the active substances which are present in the recombinant somatropin. The warning and precautions. So the message from this is that the dose of growth hormone should be individually titrated as needed with respect to age, gender, etiological diagnosis, clinical response, side effects, and determination of IGF-1 levels in serum, which may guide for the dose titration. Somatropin is to be given as a single daily subcutaneous nighttime injection on thigh, buttocks, or abdomen, and site of injection should be rotated daily to help prevent the lipoatrophy. I would like to thank you all for your kind attention, and for any queries, please feel free to contact me on the details as flashing on the slide. Thank you so much.
Thank you, Chirantab. That was a very nice presentation and very practical and interesting cases you have highlighted with respect to assessment and growth chart, and a very nice short approach which you have depicted, which is very useful for from clinical point of view. Now, I think we will go ahead with the next talk, and I would like to introduce Dr. Nikhil Shah. He is consultant pediatric endocrinologist at Bhatia Hospital, Mumbai, Fortis Hospital, Mulund, Mumbai, and Cloud9 Hospital, Malad. He is visiting consultant in pediatric endocrinology at Sion Hospital, Mumbai, and KG Somaiya Medical College. And he is associate professor in pediatric endocrine research at HCJMRI Jahangir Hospital, Pune. He has 22 indexed publications in high impact factor journals and one textbook chapter to his credit. So let's hear from Dr. Nikhil about SGA.
So thank you, Aniket sir, for the kind introduction and for laying the path, for us to take this session. Thank you, Chirantab, for that wonderful session of interesting cases. So the topic given to me today is growth optimization in SGA children who fail to catch up. I think this is a very important topic, as I think in the next few years, SGA children are going to be the most common cause of short stature if they're already not. So I'm Dr. Nikhil Shah. So the overview today we'll be talking is prevalence of SGA babies. I'll be discussing a couple of cases. What is the definition of SGA? Which growth charts to use to plot these babies? What is catch-up growth? Clinical pointers for identification of these children. Evaluation of these children who are short. Growth hormone therapy in these children. How does puberty take place in SGA children? And finally, I'll be summarizing my session. So coming to this very important part, where what is the prevalence of SGA babies? So this was a report published in 2010 in Lancet, and this shows the prevalence of SGA babies all over the world. And you can see that India has one of the highest prevalences. It's in red here. That's around 40 to 50%. So 40 to 50% of babies born in India are around SGA, out of which around 41.5 are full-term SGA and around 1.5 to 2.5 are preterm SGA. So nearly 1 in 2 babies is going to be SGA. So without wasting any time, I'll straight away dive into my cases and we'll be discussing academics as and with the cases. So this is case 1. This child was born of a cesarean section, twin delivery. Child was full term, 39 weeks. He was the first twin. She was the first twin. Birth weight was 1.9 kilos. So it is low birth weight. The second twin was 2.7 kilos. There were no adverse perinatal events. Now the child has been brought with the chief complaints of not gaining height and weight as compared to the other twin at 4 years of age. So what is the definition of SGA? I think this is very, very important. Before knowing the definition of SGA, we need certain prerequisites. So the first and most important thing is an accurate knowledge of the gestational age. So at what week the child is born. We need accurate measurements of birth weight and length. So in India, birth weight is routinely recorded, but birth length is still not recorded in a lot of the places. And we need a cutoff against reference data from a relevant population. So we need to compare the child as compared to other children. Now, there are various definitions mentioned in different places. Someone has mentioned it 3rd percentile. Someone has mentioned it 5th percentile, mentioned as 10th percentile for weight, length, or both. So what we follow is any neonate whose birth weight or birth length is at least 2 standard deviations below the mean for the infant's gestational age, which is equivalent to the 3rd percentile based on data derived from an appropriate reference population. So neonate whose birth weight or length is less than minus 2 SD or less than 3rd percentile, we would label the child as SGA, that is small for gestational age. Now, which charts do we use? So for term babies, we use different charts. For preterm babies, we use different charts. So that is the third point which I was talking, prerequisites. What is the cutoff against reference data? So for term babies, we routinely use the WHO charts. So these are the IIP modified WHO charts. On the left, you have for the boys. On the right, you have for the girls. And this is how we plot on the charts. So any child who's below this minus 2 standard deviations, so below this orange line, that is below the 3rd percentile in terms of birth length or in terms of birth weight, we label this child as an SGA baby. So for term babies, we use the WHO charts. Now, what are the charts that we use for the preterm babies? So initially we used to use Fenton charts, but now slowly we are moving around from the Fenton charts, and the charts we are routinely using for preterm babies are the Intergrowth 21 charts. Why are the Intergrowth 21 charts better than the Fenton charts? Because they've been updated. They are accounting for the secular trends. And Fenton charts had data only from one country. Intergrowth charts has data from many countries, including data from India. Around 1,000 children from the central city of Nagpur were selected for this study. So these charts, these are the so again, as I said, anything less than minus 2 standard deviation or less than the 3rd percentile. So in red, we will label these 2SD. Here the birth length is less than minus 2SD. And similarly here, the birth length, the birth weight and the birth length is less than minus 2SD. So the red ones are small for gestational age babies. The blue ones are the appropriate for age gestational babies. So coming back to our case, how do we interpret? So here you can see the child at 2 years, 8 months, and then at 4 years. What we can see is that the height has not caught up. The height is still below the 3rd percentile, but the weight has caught up. Just 1 minute. So height and weight percentile below the 3rd percentile at 2.8 years. At 4 years, the height has not caught up. The height is following the same trajectory, but the weight has caught up. So height is still below the mid-parental height target range, and height is more affected than the weight. So now coming to the important concept of what is catch-up growth. Catch-up growth is defined as growth rate greater than the median for chronological age and gender for growth rate greater than 0 SD, that is greater than the median for chronological age and gender, reaching a height above minus 2 SD or 3rd percentile, and target height also should be considered. So I agree that this slide is a bit complicated, but we need to understand that catch-up growth is when the height should at least reach minus 2 standard deviations or 3rd percentile, or it should reach the target height, whichever is more. So a child's height should reach either the minus 2 standard deviation or 3rd percentile or the target height. If it is below that, we will say that there's poor catch-up growth or failure of catch-up growth. So here an example. On left, you can see catch-up growth. So here we can see that the height has caught up. So this is a slide of catch-up growth. Here you can see our child, where this is following the same trajectory. Child is below the 3rd percentile and below the. Now, how long do we wait for catch-up growth? So in SGA babies, most of them achieve catch-up growth by 2 years of age. And this was very well demonstrated in a study by Hawke and colleague in the 90s, where 90% of the babies achieved catch-up growth by around 2 years of age. However, in preterm SGA babies, catch-up growth can occur even up to 4 years of age. 10 to 30% of children born SGA do not achieve catch-up growth. So that is a big number. And in Indian studies shown by Khalkar sir and et al., it is shown that the number can be even much higher. 40 to 50% do not achieve catch-up growth. So 1 out of 2 babies is born short. And out of these short children, 1 out of 2 babies is born small for gestational age. And out of that, 1 out of 2 or 1 out of 3 is going to remain short. short. So that is a huge number. Now, this is a classification of short stature or the various causes of short stature given by the European Society in 2009. And since last 10 years, small for gestational age with failure of catch-up growth has been included in the causes of short stature in this classification. So you can see that small for gestational age failure to catch up growth is an important cause of short stature. Now, what are the clinical pointers for SGA children? So first and foremost is anthropometry. So as we've discussed, SGA children who do not achieve catch-up growth by 2 to 4 years of age. The other clinical pointers that we'll get is you will typically have a triangular face. They will have a broad forehead and there will be facial asymmetry. So you can see that this child is having kind of like a triangular face. There's a broad forehead and there might be facial asymmetry. They might have clinodactyly and they might have limb asymmetry. So one limb is usually longer than the other limb. So these are the subtle pointers which will help us to identify SGA children. And this is very useful where cases birth weight is not known. So where you have a triangular face with failure to catch up growth, broad forehead, facial asymmetry, clinodactyly or limb asymmetry, we should suspect an SGA child who's failed to catch up. Now coming back to our case, at 4 years, the height has not caught up, but the weight has caught up. So child is definitely short, height is below the 3rd percentile and short for the MPH target range. So how do we evaluate? We do the CBC and creatinine, which is normal. We did the thyroid function test, which is normal. Bone age done was 4 years, which is corresponding to the chronological age of 4 years. IGF-1 was normal. We did not perform the growth hormone stimulation test as bone age was not delayed. As discussed earlier, this is an SGA child who's failed to catch up. This is the cause of short stature. And this children can be started on growth hormone. So we started this child on growth hormone. Now, how do we evaluate an SGA child who fails to catch up? First and foremost is a clinical diagnosis. A good thorough history, a good clinical examination will help you to clinch the diagnosis. The routine tests that we perform for any case of short stature will include is CBC, RFT, TFT, calcium profile. In India, we need to do celiac workup, especially in North Indian children. IGF-1, if there is severe short stature, bone age in SGA children. So bone age is usually very accurate in children with short stature, but in SGA children, it tends to trick us. In SGA children, bone age is a poor predictor of pubertal timing and height attainment. Yearly bone age assessment is not usually recommended in pre-pubertal children. So we usually just perform it at diagnosis. And then we repeat the bone age around at 8 years of age and regularly from the onset of puberty. As it helps us to pick up cases where there is advanced bone age, especially in cases of ACAR mutation. Genetic tests, do we do routinely in SGA children? No. Genetic tests are only indicated if there are some dysmorphic facies, major malformations, microcephaly, intellectual disabilities, signs of skeletal dysplasia. Now coming back to our case, this is a 4-year-old child who was short. We started the child on growth hormone therapy. We started at 45 microgram per kg per day. So when we started growth hormone, we've continued for 6 years. And you can see the child who was short for the MPH, child whose final height was going to lie below the 3rd percentile, has now caught up to the 25th percentile. So that's a very, very good catch-up growth there. At 10 years, the child started showing signs of breast development and slowing of height. The bone age is around 11 years, 2 months. So because of the slowing of height here, as you can see, the child was short, we've given growth hormone, there is a good catch-up. Slight slowing has happened here at 10 years. We increased the dose of growth hormone to 50 microgram per kg per day, which has led to an improvement in the growth velocity. So immediately after increasing the dose, you can see that the height has increased. So menarche of the child happened at around 12 years and we could continue growth hormone for 1 year post menarche. And you can see that the final height is now lying within the mid-parental height target range. So a child, if you would have not treated, would have fallen below the 3rd percentile. And because of giving growth hormone, the child has achieved their genetic potential. So how do we give growth hormone therapy in SGA children? So the age of starting varies from country to country. In USA, it can be started as early as 2 years. We usually follow the European guidelines. So we wait till 4 years of age. Height SD should be less than minus 2.5 standard deviations. Growth velocity should be less than 0 SD. And reference to mid-parental height should be less mid-parental height. growth hormone treatment is used, it becomes important to know the etiology of SGA. Recommended growth hormone starting dose is 33 to 67 microgram per kg per day, with higher dose used in those with most marked growth retardation or when growth response is unsatisfactory. That is, delta height gain is less than 0.5 standard deviation during the first year of treatment. So, what is the effect of GH on growth and adult height? So, these are the various studies. In white you can see the cases, and the marked ones are the controls. So, this is the height gain. So, there is a dramatic height gain in children who have received growth hormone, and this is the mean of all the studies. So, mean height gain was 1.5 SD in treated children and only 0.25 SDS in treated children on SG. And what about the final adult height? So again, the white are cases and the dark ones are the controls. So these are the various studies. So you can see that the final height is much better in cases, as you have to realize that the scale is in minus. So mean adult height was minus 1.5 standard deviation for treated subjects and minus 2.5 standard deviation for untreated subjects. So treated children were much, much taller than the untreated children. What are the other benefits of growth hormone? It improves body composition. It has a favorable effect on the BP profile. It improves the bone mass, improves quality of life. It decreases in total cholesterol and LDL. And in some reports, it's also shown to improve the cognition. Now, coming to the second case, this child was born of a cesarean section, indication being oligohydramnios. This child was born at full term, 38 weeks. The birth weight was only 1.7 kilos. So this is definitely low birth weight as well as small for gestational age. Now, child has come to us at 9 years of age for short stature. Mother has also noticed breast development since last 6 months. So this is the growth chart of the child. You can see that the height and weight of the child is between the 10th and the PH target range. On physical examination, child has some axillary hair, some pubic hair, and some breast development. Height at onset of puberty is 125 centimeters. So how do we approach? Should we just leave this case as it is, or do we need to evaluate? Do we need to intervene? So this is where SGA children trying to trick us. If we just go by anthropometry, if we look at this child, you feel that this child is going to fall within the mid-parental height target range, and we would just leave this child. No, puberty in SGA children behaves very, very different. Can have premature adrenarche and pubarche. So there is an earlier onset of pubic hair as well as axillary hair. They progress through puberty very rapidly. Typically, children from the onset of breast development till menarche take 2.5 to 3 years. But SGA children this process might take just 1.5 years. Not all, but at least 30 to 40% of the children can
Actually, your voice is breaking.
Sir, your network connection is not stable. Hello, Nikhil sir.
हेलो रुकैया मैम।
Hello, yes. Sir. Hello, Nikhil sir.
I think Nikhil sir disconnected. I think so. Meanwhile,
I guess doctor is facing some network issue.
yeah.
Hi, sorry, I think there was some technical issue. So am I audible?
Yes, sir. Yes, sir. You're audible.
So coming back to my case, so as I was saying, this is an SGA child here, and we can see that this child, if we just look at the growth chart, we would feel we need to don't need to do anything because child's height is falling within the mid-parental height range. But as shown in the earlier slide, these children tend to trick us in terms of their puberty can progress rapidly. They can have an earlier onset of menarche. So we evaluated this child because we knew that this is an SGA child. It's always safe, better to be safe than sorry. So we did a CBC which was normal, TFT which was normal, creatine which was normal, IGF-1 which was normal. We did a bone age, and bone age was 10 years, 6 months. So now if I drag this bone age ahead, the child is going to remain short, that is below the 3rd percentile, as well as below the MPH target range. So a child who looked actually normal on the growth chart, but has already started developing signs of puberty, if you do the bone age, it'll accurately tell us where the final height is going to remain. So as you can see that the predicted adult height is falling below the 3rd percentile and below the MPH target range. Now, what should we do with this child? Should we give only GH or should we give something along with GH, that is a GnRH? So in SGA children who are short at the onset of puberty, that is when the height is less than 130 centimeters in Indian girls and less than 135 centimeters in Indian boys, or in those whose expected short adult height, that is the final adult height, is going to lie below minus 2.5 standard deviations, we need to treat with GH plus GnRH alone. So you need to block the puberty or postpone the puberty and need to give GH. So what does postponement of puberty do in these children? So postponement of puberty with a gonadotropin releasing hormone analog for 2 years, in addition to GH, results in an average improvement in adult height of 6.6 centimeters above the height achieved with GH. So if we give GH and if you give GH with GnRH, so GH with GnRH is going to cause a better effect, and the effect shown in various studies. Again, a lot of this has been done in Netherlands, where at least 6 centimeters height gain was achieved if we give a combination of GH with GnRH. Again, not all cases require GnRH. We are looking at cases where puberty has set in, the child is short at the onset of puberty, and bone age is advanced. So we need to be very thoughtful in thinking where we need to use these injections. So looking at this case, we are looking that the bone age is advanced. As a result, the final adult height is falling below the mid-parental height and below the target height. So we started this child on GH plus GnRH. As a result, the bone age progression has slowed down now. We stopped the GnRH at 11 years. Menarche of the child happened 1 year after stopping GnRH at 12 years. We continued GH till 13 years, and child has now reached the target adult height. So if this child wouldn't have been treated, the height would have been below the 3rd percentile. Another important thing that we don't need to forget and we routinely see in this practice, especially post-pandemic, is the SGA and long-term metabolic complications. So we should remember never to forget screening obesity, insulin resistance, metabolic syndrome, PCOS, dyslipidemia, and type 2 diabetes in SGA children, and the otherwise also holds true. Any child of obesity comes to you, please take the birth history, as majority of these children will have a birth weight less than 2.5 kilos. So we know that this is a metabolic programming which is causing them to develop these long-term metabolic complications. So what are the take-home messages for today? use of WHO charts for term babies or Intergrowth 21 charts for preterm babies should be used for plotting of birth weight and length according to the gestational age. 10 to 30% of SGA children do not achieve catch-up growth by 4 years. So I think this is the first and foremost critical period for the pediatricians who need to be careful and need to refer these children. Growth hormone therapy is a licensed indication for SGA for the last 20 years, can be used safely. Rapid progression of puberty and earlier onset of menarche leads to final short height. So I think between 7 to 8 years should be the second critical period that the pediatricians or the primary caregivers need to be careful about. SGA children who are short at the onset of puberty, that is height is less than 130 centimeters in Indian girls and less than 135 centimeters in Indian boys, be treated with GH plus GnRH. And finally, never forget to screen for obesity, metabolic syndrome, insulin resistance, PCOS, and dyslipidemia. This is my final slide. I think birth weight and length measurement is very important. So early identification of these babies. Regular monitoring of birth weight and length is critical to identify failure of catch-up growth. So early monitoring, early and timely referral of these babies to growth specialists. So early referral and appropriate treatment of GH at 4 years instead of a wait and watch approach. So early treatment. So early identification, early monitoring, early referral, early treatment will lead to lesser morbidity and better outcomes. So thank you. This is my email ID if anyone has any doubts. I'd like to thank the Pfizer team for organizing this session, and I'll stop sharing my screen now.
Thank you, Nikhil. That was a wonderful talk. And you have highlighted, I think, many aspects with respect to SGA, both the immediate and long term. Plus, you have highlighted the puberty issues and metabolic issues in these babies. And you have also touched upon the programming, which is very important. And we should understand that the calorie dense feeding or overfeeding in these babies may cause problem to them. So appropriate catch-up is okay, but we should be cautious about that. So I think we can discuss some of the questions here. So any of you can highlight about the bone age. So what are the different types of methods which you use for bone age, and what are the pros and cons of each type, and which cases bone age may not be useful, or which cases it is useful, and how do you predict final height based on bone age?
Chirantap, you want to take this?
Yes, sir. So the methods for bone age evaluation, amongst the manual methods, there are two kinds of methods. One are the Atlas method and one are the analytical methods. The Atlas method that is available and the most commonly used one is Grulich and Pyle Atlas. And the other recent one that is available is Gilsans and Ratib Atlas. The issue with Atlas method, particularly Grulich and Pyle, is that it was made in 1950 based on Caucasian children from Stanford. So how much is it useful in today's day and age for Indian children in 2023? That is questionable. So the Tanner Whitehouse method, which evaluates the epiphysis of the radius ulna, the short bones of hand, that might be more useful for Indian setup, as it has been shown in the study that Nikhil sir had conducted. And in the automated artificial intelligence based method, there are various softwares that are available that remove the inter observer variations. So, but how sophisticated they are, that still remains to be evaluated. But Bone Expert, which has been available since 2009, is reported to be doing good in various studies. Now, based on the bone age, we can predict the final height. Like for Grulich and Pyle, there are the Bailey-Pinot tables, and there are equations for Tanner Whitehouse as well. Bone Expert also gives predicted final height when we enter a few details for the software. So those are the bone age methods and their utility in predicting final height. Particularly useful bone age is for short stature, as we have discussed, and for precocious puberty, that as shown in the second case by Nikhil sir, that the child may be within the mid-parental height range, but if the bone age is advanced, then the predicted final height is going to be short. So we are falsely assured that the child is okay, but then in the end, outcome is less than 5 feet for a girl. So that is how bone age may be useful.
So I'd just like to add here, please don't rely on the bone ages given by radiologists, because many of them are still following the Kapil method. I agree. I guess even Aniket sir and Chirantap will agree with me that, radiologists give a different sort of bone age. They'll give a range 7 to 9 years, 9 to 12 years, which is not very useful for height prediction and calculations. So I think either do your own bone ages or please refer to a specialist. Yeah.
And you can just talk about the monitoring aspect also. Suppose you are treating a precocious puberty or growth hormone deficiency, how frequently you want to monitor, how do you go ahead with that? That also I think we can discuss.
So I guess we can take it yearly. What I would do in my practice typically is have a yearly assessment of bone age, especially in precocious puberty, just to know whether therapy is working, whether there is progression of the, how fast is the bone age progressing. Typically on starting the GNRH analog, you will see that there is a slowing of the bone age. So bone age, which was rapidly progressing, now has started slowing down. As a result, the height will also start slowing down. So in precocious puberty, at least yearly. Short stature also I would do yearly. Just to know how much time do I have and, do I need to up my dosages and like that. Yeah.
So now we have growth hormone, which is approved for many conditions. And we want to talk about practical aspect of the response. So in which cases you see a good response, which cases you are very, because, at the end of the day, it all boils down to what parents expect. And Turner syndrome girl is there, and you are asked with this question that how much this girl will benefit from growth hormone. So it is very important that we give a clear message to parents and the referring pediatricians also, that so what is your take on this, the response on different indications?
So sir, growth hormone, the dose of growth hormone is lower for growth hormone deficiency and multiple pituitary hormone defects, and the response that it gives is better in the growth hormone deficient cases. Whereas as opposed to conditions like SGA, idiopathic short stature, Turner syndrome, where we approximately need 50 microgram per kg per day or higher doses, even the IGF-1 values are high. So in those cases also, growth hormone does give a good response, but the response is not as spectacular as in cases of GHD. Also, the timing of initiation of growth hormone, the duration for which growth hormone is given, all those, and the pubertal, the onset and progression of puberty, all these factors also play an important role in it. So, considering in our country, like where cost of growth hormone therapy is huge, but we can still expect a height up to -1 standard deviation from the mid-parental height in cases of SGA, idiopathic short stature, wherein on giving higher doses of growth hormone at an earlier age for a duration of 4 years or so, then we might be able to give good height to the child. For GHD, though, it will it has more of a linear response. So for GHD, the gain is quite visible to the naked eye as well. So intermittently, because affordability is an issue, so sometimes intermittently we give growth hormone, which is earlier we give once the child has caught up, then we stop for a certain period of time, and then again during puberty to push the growth spurt. However, ideally it is recommended that it should be given till the bone age has fused or the increment is less than 1 centimeter per year. But the practical aspect of it is that we may have to compromise on the duration of therapy to consider the cost issue.
And which cases will not consider growth hormone?
So as in my presentation in the last case, we saw that the child developed antibodies to the growth hormone. So after a good initial response for 2 years, there was flattening of response. There are various other conditions wherein growth hormone is not useful. Those are termed as the growth hormone insensitivity syndromes. Earlier, they used to be called Laron syndrome, but now a broader term, which is growth hormone insensitivity, is used, wherein the defect is beyond the production of growth hormone, that is at the growth hormone receptor level or at the IGF-1 production level or at the IGF-1 receptor level. So in those cases, growth hormone might not be able to give the response. So Increlex is the product which may be used, but it's not available in India, and the cost is beyond our imagination. So I think, yeah.
So one more thing I think clinically relevant, which we can discuss, is multiple pituitary hormone deficiency. So how do you think the clinician should suspect MPHT? There are two types also. It may present in early infancy also, and they can present later also. So what are the clinical clues, and what are the important management aspects also, which a pediatrician should be useful, because the replacement of hormones, the sequence and everything is very, very crucial if you suspect MPHT. So can you just highlight on that?
Yes, sir. So as you said that MPHD may be presenting earlier, might be the congenital cause, which are these genetic forms like the PIT1, PROP1 mutations, wherein clinically the clue that is present is presence of any midline defect, like there is history of breech delivery, there is presence of clip or cleft palate, there is ophthalmic abnormalities, and some sort of any midline defect or some syndromic features are present in those child. Whereas in the acquired cases, any space occupying lesion like craniopharyngioma or any intracranial tumor, they may cause the pressure effect on the pituitary, and more than that, post removal the pituitary gland may be damaged, so that may also cause multiple pituitary hormone defect. In terms of replacement of the hormones, so for the acquired causes, we must pre-operatively we must evaluate these hormones, and they must be replaced before the surgery as well, to avoid any damage like cortisol, or to prevent any development of crisis. After the surgery, between the main issue in initiating the hormones is for thyroxine and cortisol. So what happens is that once we start thyroxine, it causes increase in metabolism of cortisol, and the adrenal insufficiency, which may be masked, may manifest itself. So that is how the initiation of these multiple pituitary hormone defects should occur. And the growth hormone for craniopharyngioma may be started safely after 2 years. However, recent literature says that even 1 year is a good age to start growth hormone. Post-surgically, if there is any presence of triple phase response and there is development of diabetes insipidus, then even posterior pituitary hormone like vasopressin replacement may be needed initially in the post-op period.
Okay. I think we have discussed most of the things. As a take-home message, if you both of you can just give a final, good message we want to give, you can just give, and then we can actually wind up.
So I think I would say that most and foremost important is plotting of growth charts, asking of birth weight. So early identification. So if we take the birth weight, we take the birth length, we know that whether the baby is SGA. So early identification, monitoring these babies at every vaccine visit, every sick visit. So early monitoring. At 4 years, if there is failure to catch up, so that will be an early identification, and then referral. So then, at the right time, the right things can be started. And these children tend to progress through puberty very rapidly, can have an earlier onset of menarche leading to final short height. So I think the second critical time point would be at the time of puberty that these children need to be looked after. So yeah, these are the take-home messages.
I would just like to add that investigations must be performed to confirm the diagnosis rather than finding the etiology. And so they must be used judiciously. Like one must not do everything in every child of short stature. One must first make a probable diagnosis and then go ahead investigating it. Genetics is not the final answer to everything. So be very careful in ordering tests that are very expensive for the patient. And if indicated, growth hormone should be given because it gives a lot of importance, not just cosmetically, but even psychologically to the child, that it gives certain amount of confidence. And for some recruitments like police and all, you need a certain height. So it may be useful for such cases as well. So yeah, rest all has been covered, the take home message.
Okay, thank you very much. Both the young and dynamic pediatric endocrinologists have taught us very nice and highlighted the most important clinically relevant points. I would like to hand over to Pfizer people for concluding remarks.
So, sir, first of all, thank you for this lucid and wonderful presentation on short stature as well as growth optimization as the children who fail in catch-up. So I would like to thank Dr. Aniket for moderating the session in a wonderful way, and Dr. Nikhil Shah as well as Dr. Chiranta for taking session way forward. So with this, we can conclude this session. Thank you, Dr. Aniket, Dr. Nikhil, and Dr. Chiranta.
Thank you. Thank you.
Thank you very much.
Thank you. Thank you.